If you are a woman over the age of 40, you are probably getting bombarded with information about perimenopause and menopause. And while it's great that we are finally talking about this natural transition that all women experience, sifting through all the information, what's fact, what's not, can be difficult and overwhelming. Today, we're going to talk about women's health, what you need to know, and of course, the transition to menopause. I'm Betty Wang, host of Betty's Smart Friends. I'm a certified financial planner who helps women be more empowered and feel less alone in their financial lives. Today, joining us to help us filter through all the information out there is Dr. Sonia Novotny. Sonia is a board-certified OB-GYN and member of the Menopause Society. She's practiced at Kaiser Permanente for almost 14 years and is the Associate Medical Director for the Metro OB-GYN Department. Sonia is passionate about women's health and supporting women through all of life's journeys. She listens to her patients and empowers them with information based on science and evidence so that women can make the best healthcare decisions for themselves. I'm so excited for Sonia to share her knowledge and experience with us. Please welcome Sonia Novotny, Dr. Sonia Novotny, to the podcast. Hi.
Oh, thanks, Betty. What an introduction. Thank you.
Thank you for joining us. I'm excited for us to chat about this. In our private conversations, I found you super knowledgeable and loved your approach with how you talk with patients and how science-based it is, right?
Oh, thanks.
Yeah. Can you tell the listeners a little bit about your background? I mean, obviously you're a doctor.
Yeah. So I live here in Denver, Colorado, and got to meet Betty through our sons. They're in a robotics club together, so that's been really fun. And so I graduated from Cherry Creek High School where our kids went, and I still get to live in the neighborhood, and it's fun to see my kids go to the same schools. I went to Rice University in Houston for undergraduate, and I met my husband, John, there. He's an electrical engineer. And then I came back to Colorado for medical school at the University of Colorado. And I wasn't sure if I wanted to do family medicine or surgery, but I found OB-GYN to be a really great combination of all those things. And it was always exciting. I felt like you were always getting to interact with people at some of the most important times of their life, thinking about being sexually active, what it means to prevent infections, to prevent pregnancy, and then trying to become pregnant, and thinking about fertility and like what an important time of life that is. And then supporting people through their pregnancies, and now supporting people through menopause and all that comes with it. So it's been a really exciting field for me, and I get to do so many things, from routine preventive care to troubleshooting problems, to delivering babies, to doing surgeries. And one of the things that I've enjoyed the most is menopausal care. So when I was a medical student at the University of Colorado, I chose my residency as one that would kind of help me start a career with Kaiser Permanente, because I really found it to be the kind of model of care that I wanted to deliver, that was evidence-based, not fee-for-service, meaning that I really get to offer people the things that I believe in, and I don't necessarily have a financial incentive in what they choose. I don't make more money by ordering more tests. I don't make more money by recommending specific treatments. And so I've really been thankful for that in my career, that I really get to present my patients with the options that I really believe in and think are best. And I am happy with whatever they choose. I will order whatever labs that they feel they need or whatever treatments that they think suits them best. And I really just get to keep my role as giving them the best information that I have. That being said, everything is always changing, especially when it comes to menopause. So things that I thought were true 10 years ago are not true today. And I'm sure a lot of the information that I will share will be changing, and will be adopting new ideas and new technology. So I'm really aware of that, and really humble that things are changing. I don't know everything. And there are so many ways to approach this. And I liked that you said that a lot of people are talking about menopause, because I feel like I'm always hearing that nobody's talking about it. And that really makes me sad. And that's why I was so excited when you invited me to this podcast, because of course in my world, I'm always talking about menopause. But I realize that especially now, people get a very distinct algorithm or feed where maybe they're only hearing about menopause like me. Like even my New York Times feed is all about menopause. But I can understand that that may not be the algorithm that everybody gets. I listen to a lot of podcasts on menopause too. And I don't know where I heard it, but someone once said something that really resonated with me, that even though everyone might be talking about it, nobody is talking about your specific menopause journey. So it's always going to feel like to some people that maybe nobody's talking about it because no one is going to have the same experience as you and the same path as you. Which I think really gets to the root of it, that it's such a personalized journey and no one is going to have the same constellation of symptoms and no one is going to benefit from the same therapies. I'm excited to just give you some insight into how I think about it, how I present it to my patients, because I know it's going to be different. Even from my other partners at Kaiser, definitely, different providers and different venues. And I think it's nice for people to just get a lot of different perspectives because pieces of what I say or other podcasts or, other sources are going to suit everyone better.
Yeah, I must be on the same algorithm as you because, and really part of the reason I started these podcasts is because literally all my friends and I talk about are perimenopause and menopause and what we don't know, what we do know, and sharing little tips that we've heard here and there. I've gotten to the point where if I get a paper cut, I blame perimenopause because I really think it seems like everything that's going sideways, like somebody cuts me off in traffic, perimenopause. Like it seems like all these changes, it's just very hard to know what to do and where to find information, right?
Yeah. No, I hear that. And as someone who's, like consuming a lot of this information, I also struggle to really have a clear picture of, what I want to say and what I believe in. So it's a lot to wade through. So I'm also a member of the Menopause Society. It used to be called the North American Menopause Society or NAMS. I had a NAMS certification before COVID that I let lapse after, and I'll probably restart that again. And so that's a good resource, the Menopause Society. They also have a provider database, and you can search for physicians and nurse practitioners or advanced practice providers who are certified through the Menopause Society. A lot of our data comes from a study called the SWAN study. And the SWAN study actually has their own website, which is really, really high quality. It's called swanstudy.org. And we're really lucky. The woman who's the president this year is from the University of Colorado. Her name is Nanette Santoro. She's a reproductive endocrinologist on staff at the University of Colorado, and she is very active in publications and organizations. She speaks a lot. And so there's a lot of good data there. And the SWAN study is like a longitudinal study that's been going on for a lot of years in a lot of locations. And as Kaiser, we also have patients that have contributed to that data set. So a lot of the information. So I kind of use the facts and figures that come from the Menopause Society, and they get a lot of their data from the SWAN study. So I think those are really great places to go for information. And that's sort of kind of the mindset that I come from.
So I guess for those of us who don't have the medical background, how do you approach your patients? Like, how do you bring up these discussions? Because it seems like maybe I'm not alone, that we're just hearing about this, right? Like, I wish I had known that perimenopause could start at age 40, right? It seems like you were kind of ahead of your time or had a lot of foresight by joining this Menopause Society, 5-6 years ago or before, prior to COVID. How do you typically approach, or when do you start having these conversations with your patients?
Yeah. I definitely, a lot of people have concerns about, they feel tired, they feel like they're gaining weight, and they want to talk about menopause. And like you said, can it be perimenopause or menopause? Yes, absolutely. Almost everything can be linked to that.
My paper cut?
Probably.
Yeah, I know.
being alive and aging. And overall, I guess what I want to say is that I think that this is a normal physiologic pathway. And we're all going to experience it differently. And for some people, some of these things can be managed, in being the healthiest version of themselves and giving it a lot of time. But there truly are people who are struggling and want more interventions. And that is very reasonable too. And just sort of understanding the lay of the land and all the options that are out there can help you make the best decisions. And so, sometimes I hear podcasts where people think that like everyone needs to be on this set of supplements or treatments or that, and I don't believe in that, but I certainly believe that there are people who need more and people who might not need as much at different times. So I just always start with just the definitions. And so the first thing is just understanding, like our reproductive life and fertility. My kids hear this discussion all the time.
Interesting.
And I have heard both little boys, not little, teenage boys. And I've overheard them explaining, the menstrual cycle. I don't think that that's very popular when you explain the cycle to girls. They have told me that does not win friends. The way I explain it, which I've heard them also say is, when you are an embryo, you have the most eggs that you'll ever have, about 5 million. And by the time you're born, those have already, kind of been absorbed by your body, that now you only have about 1 million eggs by the time someone's born. By the time someone goes through puberty and starts their period or menarche, there's only 500,000. And so with each menstrual cycle, you are losing eggs. And so this just gets the concept of reproductive aging. So by the time you're in menopause, which clinically just means 12 months of no periods, and that's for women who haven't had a surgery that makes them have their period stop or don't have an IUD that stops their period. Like in the absence of surgeries or medications, 12 months of no period, that is menopause. And you essentially have no eggs. That can happen naturally anytime after the age of 40. If it happens before, that's premature ovarian insufficiency, and that needs a very specific workup because there could be genetic issues at play, and it's worth having a very thorough evaluation. And those women should get treated with hormones because having premature ovarian insufficiency has big repercussions on your bones, and your heart and your overall health. When this process happens after age 40, that's within normal. The average age for menopause is between 51 and 52. If this happens before age 45, that's on the early side. And if it happens after age 55, that's on the late side. But average means, half of women won't go through menopause until they're 52. So there's such a huge range. We have some good ideas about how long your symptoms will last by a big kind of model called STRAW, stages of reproductive aging. But the windows are really, really big. So in my sort of truncated view of it, if you have hot flushes and you've noticed that your cycles have changed, there's more spaced out or closer together, on average, you can expect that your period would stop within 5 years.
Okay.
So that's a really big window. We know that women who describe their ethnicity as Asian, Chinese or Japanese, on average have a shorter duration of menopausal symptoms. Yeah, 4 to 5 years. Maybe it's the diet. I don't know. Maybe it's the genetics. And women who are Black will have a longer duration of symptoms, on average 10 years. So there's a lot of difference in the length of symptoms. We know that things that can make the symptoms more intense are having a higher weight, smoking, alcohol use, sedentary lifestyle, life stressors, anxiety. Those can make menopausal symptoms worse. Mm-hmm.
No, I just do the symptoms stop after menopause?
Yeah.
I guess asking for a friend.
So they get better for most people. And when I started doing this work, our thought process was like, you won't need these after a time. Like everyone just needs to be off hormones. Like all of these symptoms will stop. We have really good data from this SWAN study that a lot of people, probably 40% of people, continue to have hot flushes. Are they bothersome enough to want prescription medication? Maybe not. Maybe that they're much less. But it's a huge portion of women that'll have ongoing symptoms. But they probably will be better. The reason that they're so difficult in perimenopause is that you have these very irregular cycles. So because you have less eggs and their quality is so low, in some cycles you will ovulate, and you'll kind of go through these normal ups and downs of estrogen, which is the first part of the cycle. And then usually when you ovulate, now it becomes a progesterone dominant part of the cycle, the luteal phase. And you may not ever get into the luteal phase for a month or two. And then you ovulate and you do. And so you have these huge fluxes of hormones. And that's what makes hot flushes so severe. Most people will have hot flushes or, the sensation of feeling warm and sweaty at night. Those are a lot more common than daytime. Yes. And that's a really big deal. When it's happening at night, it is fragmenting your sleep, and getting poor sleep affects everything. It affects your energy. It affects your mood. It affects so much, more inflammation in your body from having poor sleep, increased cortisol levels. So when people say that they're noticing fatigue or weight gain, is it menopause? Yes. But a lot of it can just be like the natural changes in metabolism and aging. But that's, a place that we can really target and talk to people about opportunities to help them there. One really big thing that I see as like a generalist OB-GYN is irregular bleeding problems. And so because you have such irregular cycles, there's a huge opportunity for irregular bleeding. And these are going to be exacerbated for people who are higher weight, which is most of us, because our fat cells also make estrogen. So the ovaries make a more potent form of estrogen called estradiol. And so in perimenopause, you still do have estradiol and progesterone from the ovaries. But when you're postmenopausal, those levels are extremely low, virtually zero, but you're still getting estrogen from other tissues, specifically your fat cells. They make a weak form of estrogen called estrone.
Can you talk about what exactly estrogen does? Like,
Yeah.
what is that the reason, like, my skin's drying out, like my hair is falling out, or what does it do for you?
Right. So estrogen is, the dominant hormone of the first part of the menstrual cycle, the follicular phase. And so in that estrogen dominant stage of the cycle, all the follicles, many follicles are competing to be the dominant follicle that you would ovulate. And in perimenopause, sometimes you can get stuck in that cycle. And that's especially why people can have like more breast tenderness or other symptoms. So many of our tissues are estrogen dependent. So being in perimenopause or menopause where you have lower levels, because there's that flux in perimenopause, and in menopause solidly, when you've had 12 months of no periods, your estradiol levels from the ovaries are really low. And we know that definitely the tissues of the vagina, the vulva, the urethra, which is the entrance to the bladder, they are super, super estrogen dependent. So beyond hot flushes, the number 2 complaint is vaginal dryness, painful intercourse, bladder irritation, frequent urinary tract infections, because those tissues are just so estrogen dependent. So a lot of those are like very, very common symptoms, and those don't get better, unfortunately, as you go through menopause. The hot flushes, yes, because you don't have these huge fluxes, but you're going to be in a chronically low estrogen state in an ongoing way when you're in menopause. We also know that collagen is estrogen dependent. So what you're noticing about changes in skin or joints is real. Because collagen is very estrogen dependent. So a lot of people do notice skin changes and elasticity, joint changes, those sorts of things. So those are real.
What other symptoms do people come to you with that, those are big ones, it sounds like, but like I have not really. Well, I guess I had heard about the vaginal dryness, but but
Yeah, and
it's interesting to hear what you see, what finally brings women to bring it up, right? Because I think I shared a statistic with you that the World Health Organization that only 49% of women in perimenopause spoke to a health professional. I mean, if I had known that I had started earlier, I probably would have. I was in my 40s. You're raising kids. You're tired. Like that's you just think that that's just
yeah,
life.
yeah,
Now
yeah.
looking back in hindsight, I'm like, oh, I wonder if those were symptoms of something else that I maybe should have known to address or started to address earlier. What symptoms do you do people most come to you with after those two biggies, right?
Right, right. So actually, statistically, the thing that brings most perimenopausal women in is irregular
Okay.
bleeding. Yeah, so 70% of visits by perimenopausal women are for irregular bleeding, according to the Menopause Society. So that's a big opportunity to talk to people about this process, about, the physiology of what's happening, and to start talking about treatments. When someone has irregular bleeding in this time, it's usually because of these anovulatory cycles. And one thing just to put a plug in is we want to make sure that this isn't a sign for anything more
Mm-hmm.
worrisome. So if you have more than one bleed in a month, if you have a prolonged bleed, meaning like more than 7 days, very heavy, we need to see you in OB-GYN. The things that we think about are to do a biopsy inside the uterus to make sure this isn't a sign for overgrowth of the lining of the uterus or cancer. We know that up to 5% of women with irregular bleeding that's prolonged and heavy and frequent really could have uterine cancer or endometrial cancer. Those are the same things. The incidence of this is going up because more people have more estrogen in their bodies because of higher weight. Being overweight or obese are the biggest risk factors for endometrial cancer. So we do want to make sure we're not missing that. We also think about infections, about structural issues that could cause bleeding. So fibroids or polyps, those are usually benign growths in the uterus. And those can be more common in perimenopause just because you can have much higher levels of estrogen or more prolonged exposure to the estrogen part of the cycle. Once we've made sure that, those things aren't happening and that we've addressed those more specifically, for people who don't have an ongoing issue with this, you may not need treatment, but a lot of times the treatment could be to add progesterone because that's what you're missing in this cycle. So that could be an oral medication. It could be a more long-acting progesterone like a Mirena IUD. I'm a huge fan of the Mirena IUD, and it's a really nice thing for people who are perimenopausal because it sits right in the uterus, giving a very small and steady state dose of progesterone. So you can, have some protection against this irregular bleeding of perimenopause. And it also gives you a birth control method because it's really important to say that fertility declines every decade, but you are not infertile in perimenopause.
Yes.
um, yeah. And so people absolutely do become pregnant because if you have any periods, you can become pregnant. Yes, your fertile potential is much lower than it was in your 20s and your 30s. But if you get periods, you can still become pregnant, and you still do need to think about having a birth control method because becoming pregnant in your late 40s and early 50s has a lot of complications associated with it. Also, very high risk for miscarriage, but a higher risk for hypertensive disorders, for twins, for complications with the delivery. So it's, yeah, just worth putting that plug in.
Yeah. And can you explain what progesterone, like low progesterone, like what symptoms come about for, and just so that we understand what it does?
Yeah, yeah, yeah. So progesterone is the dominant hormone of the second part of the menstrual cycle, the luteal phase, that comes after ovulation. And so some people might notice that they feel a little bit moodier with progesterone. It's the hormone that kind of stabilizes the lining of the uterus. And so when you don't have that progesterone, when you're like in an estrogen dominant cycle, you may have irregular bleeding. So adding the progesterone can stabilize the lining and regulate bleeding. And so sometimes taking oral progesterone for some women, it can cause mood changes. Everyone is really different, but that hormone is more of a culprit. So getting progesterone through an IUD where it's not circulating through your bloodstream can be a nice option for people. The Mirena is FDA approved for 8 years as a birth control method, but 5 years if you're using it more for bleeding irregularities. We do use it to balance hormone replacement therapy, which I'm sure we'll get to here soon. But that's not what it's FDA approved for, but it's a very common use of it. And so we would use it for 5 years if it's balancing estrogen replacement therapy. Another thing, oh, go ahead.
No, I guess I'm just trying to understand how do you know what the right balance is? Like, I'm sure
Yeah,
it's kind of art and science, or, we hate to hear that's trial and error but it sounds like it might be a little bit.
it is. I know, I know.
Yeah, yeah.
Yeah, I wish the female hormones had more transparency, but they don't because you and I could have the same exact levels of estrogen and progesterone and feel very, very different. The normal range of hormones is super, super wide. So when people who have like pretty regular cycles, come to me saying, I don't feel well, I think it's my hormones. I say it really could be. Unfortunately, doing your labs, if you're getting a regular period, especially, it won't give us much insight. In my world, I am happy to check whatever would give you peace of mind. But the normal range is really wide. And I know you're in the normal range if you still get mostly a monthly period. Every day of your cycle will have a different balance of estrogen and progesterone. And so checking these labs is not always that useful because we can't say that at this level you feel poorly and this level you feel well. It's, some hormones are kind of like that, like thyroid hormone. But the female hormones aren't like that. Testing hormones still can be useful if people have reasons to not quite know if they're in menopause. Like, for example, if you're like me and you have a Mirena IUD, I haven't had a bleed in 15 years. And so I may not know, when I'm going to be in menopause. And so checking an FSH can be really useful. That's the hormone that your brain sends to the ovaries. And so if your ovaries are working normally, that FSH should be pretty low. But if your ovaries are pretty quiet, like you're at the end stages of perimenopause or you're postmenopausal, they're not putting out much hormone and the brain has to send a really big signal to the ovaries. And so we'd expect that FSH to be high, at least a level of 25 or greater. The way we kind of think about hormones is a little tricky since we don't have great nomograms. So we kind of think about it in the setting of fertility because we have a lot of information there. So checking hormones roughly on day 3 of your cycle could be really the range of day 2 through 5 is sort of our standard on how to interpret these levels because, FSH and estradiol, they fluctuate so much. So having like these day 3 labs, day 1 is the first day of your bleeding. And so checking labs on day 3 can give us more information because that's how we assess people's fertility. And so when we're thinking about fertility and you want your FSH to be less than 10 on day 3 to say that you have normal fertility, an FSH greater than 10 means that you have diminished egg quality, and an FSH greater than 25 means the chance of getting pregnant are extremely low and you don't even need a birth control method. So sometimes we check those labs because, people might wonder, like, should I replace my IUD? Do I even need this? Or I don't know where I am in this cycle because I've had an IUD or I have my uterus out, but I still have my ovaries, or maybe someone has had an ablation where we burn the lining of the uterus because of irregular bleeding. And so those people may not know.
Yeah, because I've
Yeah.
had a couple of friends who are like, oh, I got a blood test and they told me I'm in menopause. And so it's likely that FSH test, not
Yeah. The
like
FSH,
not the other, like estrogen, progesterone tests.
those are really hard because you're getting estrogen from other parts of your body, from your fat cells. And then there's also the interconversion of testosterone and estrogen. And we get most of our testosterone from the adrenal glands, little glands that sit on top of the kidneys. And they make testosterone our whole life, but the amount of testosterone just declines gradually as part of aging, not necessarily like menopause. But people can notice that some of the things that we associate with testosterone, like libido or energy, do get lower in menopause because you do get testosterone from the interconversion of estrogen from your ovaries to testosterone. So your overall testosterone does decline in menopause from that, and also just like the natural age related decline, if that makes sense. And so for people who aren't quite sure where they are, FSH is a big hormone to test. But that being said, it's a proxy for menopause because menopause is really 12 months of no bleeding. So if you still do, have your uterus and you haven't had an ablation, I can't promise you that you won't bleed with an FSH greater than 25, but I can say that you are very likely to stop your periods very soon in the next 1 to 2 years, that you don't need a birth control method.
So I guess let's jump into treatments because I've had, I've heard of people starting testosterone as part of their overall health strategy. I mean, the HRT is obviously something that, we've talked about the Mirena. Can you explain, is testosterone part of the HRT? Or I guess, could you, let's start with, okay, they come in, they
Yeah.
have irregular bleeding, and so that's where we start with possibly the Mirena. And then let's say symptoms continue to get worse, night sweats come, the hair loss, weight gain, insomnia, loss of libido, mood changes.
Sure.
Where do we
Yeah.
go there?
Yeah, absolutely.
I mean, I know
And
it's
I would
not
say, yeah,
linear, right?
but I definitely see this scenario all the time. Yeah. Yeah. And so, I just start by talking about that this is, a normal process. It doesn't have to be, always something that's considered pathologic because for some people it's really manageable and they may not want a prescription treatment. That some of the wellness things that seem very simple are very powerful. Exercising regularly, getting a healthy diet, rich in fruits and vegetables and antioxidants, a high protein diet, like a Mediterranean sort of diet, has been shown to be a really big deal. Limiting alcohol intake to ideally less than a drink a day. Ideally a lot less than that, but definitely no more than a drink a day. Not smoking, regulating your caffeine intake. Those are really, really powerful. So it's worth saying, even though a lot of people are already very diligent about doing those things, but they're meaningful and impactful.
Well, while you're on, what do you think about the weighted vests? Right, I started doing
Oh,
that. I've started to see more
oh,
people do it because I had read the menopause book by Dr. I can't. She's everywhere now.
yeah, yeah.
But I have started to notice other people wearing them, even in California when over spring break. I
Oh,
saw. Is that helpful? Is that the weight bearing? I think it's touted as helping you with
yeah.
weight bearing and posture.
Uh-huh.
Um,
Yeah.
what are your thoughts on that?
Oh, yeah, you know a lot more than me about these weighted vests. I can definitely say that like all exercise is good
Okay,
exercise.
okay.
That like weight bearing exercise in specific is a big deal for perimenopause and menopause because we really need to work on protecting our bones. Our bones are really metabolically active. They're kind of getting destroyed and built up at the same time. And that equilibrium shifts in menopause and they're getting destroyed by our cells faster than they're getting built up. And so we want to be very careful that we're getting that weight bearing exercise in any way possible. So I need to look more into these weighted vests,
Yes.
but that's totally amazing. And any form of weight bearing exercise and being really aware of bone protection is a big deal
What
for
what's
perimenopause.
considered weight
Hmm.
bearing exercise? Like, so I guess wearing a weighted vest, um,
Yeah,
strength training, but
right.
is yoga or Pilates where it's you're using muscles, but you're not. I mean, you're not using heavy weights. Can that be considered your weight bearing exercise, or do you really need to wear a weighted vest or add
Right.
weights? I mean, that's always been a little confusing to me.
Right, right. I think lots of parts of yoga where you're using your own body weight to create resistance does count as weight bearing exercise, but also doing like more dedicated strength training. With weights, they don't have to be big, but peripheral weights and, machines that help with that, I think should be our goal. I am not perfect at any of those. I don't have a perfect solution. I am just trying. So I think whatever you can do that makes sense to you to do both cardio and to get that weight resistance is you're winning.
I guess while we're
Yeah.
still talking about lifestyle changes, before we get to the hormone treatments, is what are your thoughts on vitamins and supplements? I mean, again, the this menopause book touted creatine, and lots of different vitamins to help sup fiber. And it's hard for us to know what we should or shouldn't be doing. Do you recommend any supplements, or what are your thoughts on that? And I guess, should people start with that first before, like, trying, I guess, hormones or something or medicine?
Yeah, yeah. Supplements are really hard because they're not regulated by the FDA. So they don't tend to get as good quality studies as our prescription medications do. I definitely think that there is a lot of benefit that we are still learning about. So I definitely am excited to learn more. I will say that from my perspective, there's not a lot of high quality data to recommend the supplements as treatments for hot flushes or night sweats of menopause. Um, these supplements can be really expensive. And so I think that for people who have um, that financial capability or energy or time to do those, most of these things are not dangerous. But I cannot promise outcomes from them. I think having a healthy diet, focusing on fruits and vegetables, fresh foods, limiting processed foods, increasing protein in your diet, getting whole grains and fibers, which is hard to do. But if you can do those, that's essential. You need calcium. If you can get that through your diet, amazing. I know a lot of people aren't able to get a lot of calcium through their diet. Dairy products work, yogurt, cheese, foods that are fortified, like almond milks or soy milks that are fortified can count. If you can get 3 to 4 servings of foods with calcium, you're set and you can get the calcium that your bones need. But if you're not able to, I do recommend a calcium supplement with vitamin D because most of us are deficient. So that's the supplement that I do recommend, calcium with vitamin D. But if people can get these through their diet, that's my perspective. I know there's so much information coming, but I don't think at this moment there are enough high quality studies for me to really tell my patients who are maybe working 2 jobs and are single moms and really trying to be judicious with their time and money that there's good data for that. But I think if someone has the energy for those things, most of these things are not dangerous and you can absolutely try them. And I'd love to hear about those experiences, but I'm not recommending those in my practice.
No, I mean, that's a
There
really
have
good
been,
perspective, right? Because we just don't know.
yeah,
And
yeah,
that's
there's
a lot of
so
it.
much we don't
Yeah, a
know.
lot of it is being touted, and people say it very strongly. So and if you hear it
Yeah,
enough, right, you're like, well, maybe there is something to it. Um,
right.
and it's usually, yeah, I've also heard magnesium and the biotin, and It's hard to know what to take in, right?
Right. I mean, I think that there's good data that magnesium can help muscle spasms or leg cramps, and restless legs can really be a contributing factor to poor sleep. Not all poor sleep is perimenopause,
It's
could be
not.
restless legs. It could be, but it's worth if, poor sleep is your main complaint. We also want to think about other things like your thyroid, restless legs. Could you have sleep apnea? Other diseases, diabetes can affect sleep. So it's worthwhile, talking to your physician about these things too, but I don't have all the answers. I'm certainly open to hearing more things. And sometimes I listen to podcasts and people have like a very beautiful list of all these supplements that you should take. And I wish I really could also get on board with that because it sounds so nice. Like you just take this combination of things and you will feel
Yeah.
great. But unfortunately, I don't think that there's strong data for that. There was a lot of excitement about black cohosh, which is a plant-based form of estrogen. And when we have smaller studies, it shows benefit. But when it gets big studies, it doesn't truly show to have benefit. The same goes for evening primrose oil. I have lots of patients who swear by those things. I think they're very safe things to try. And if you are a person who really likes to try natural things first, I think that's appropriate. But if you're saying that you are suffering and you can barely work and take care of yourself and your kids, I want to let you know that there are things that are better proven, and you may not want to kind of try those things. It may not be worth your time and money. The only people who shouldn't do black cohosh are people that have chronic liver disease. So it's safe for most people.
So
Yeah.
yeah, that's a great segue to, so what do you recommend, right? What's the next
Yeah.
step?
Yeah. Yeah. So I present people like lifestyle things that we should probably all be doing.
Yes, we would
That,
all, yes. I wish that
yeah,
came in a pill too, yes.
I know exactly. That'd be great for
Yeah.
me. And so I do, tell people that these supplements are out there. The data to show their efficacy is limited. But I have a lot of people who say, actually, that's for me. That's what I want to try. And I am happy for them. And I ask them to let me know how it's going, because if it's great, then perfect. But otherwise, then I can talk to them about prescription options. The next sort of category of medications I talk about are the SSRIs, selective serotonin reuptake inhibitors. So this class of medicines was initially marketed for mood
Right.
changes, anxiety, and depression. But we know that increasing serotonin, which these medications do to help mood, is also part of the hot flush pathway.
Interesting.
So this can be an option for a lot of people. One of these medications, Paxil or paroxetine, the manufacturers went to the trouble of getting an FDA approval. So we know that 10 milligrams of Paxil is really effective at treating hot flushes. It's not as effective as hormone replacement therapy, which we'll talk about next, but it can help like 40 to 60% of people. So there are people who may not want hormone replacement therapy, who have a strong family history of breast cancer, because some cancers are hormone dependent. So if you have a strong family history of breast cancer or being treated for breast cancer yourself, or if you have uterine cancer, or you have contraindications to hormones. So beyond those cancers, that would be a really high risk for heart disease or blood clots. This may be a good thing for you to try. We know that other medications in this class also help hot flushes. It doesn't just have to be Paxil, even though that's the one with the FDA approval. So the one that we use most commonly in practice is Effexor or venlafaxine. That one does help. Paxil is more like 40 to 60% of people, and Effexor is more like 50 to 60% of people.
Oh,
So it doesn't help everybody, but it's definitely an option for people who don't want hormones or have health reasons that would make that not a good first line treatment. You would need to take these medications for at least 4 weeks to see the benefit. They're not immediate. They will not help with vaginal dryness. They will not help with libido, and in some cases, they can actually decrease libido. So it's important to know their limitations. They're really shown to just help with hot flushes. A lot of people notice mood changes in menopause, and that's tricky because there's lots of kind of lifestyle things that are happening around the time of menopause that may be contributing to that. For a lot of people, their relationship might be changing as their kids are growing up and leaving the house. Maybe their role as a mom or their role at work is shifting. They might have aging parents, excuse me. And when I was in medical school, we learned that that was really the cause of menopausal symptoms. And we don't think that anymore.
Was it that aging parents made you menopausal?
Or just like lifestyle,
Oh,
like
interesting.
changing life
Yeah.
status is a huge part of
Oh, that's
menopause.
interesting.
Um, yeah, and so that's definitely something to acknowledge, but certainly also just the actual hormone changes themselves
Yeah.
can be a huge part of mood change, and the fact that a lot of people have fragmented sleep. I know that when I don't sleep, I have a very different mood.
Yeah.
So I think that there's a lot of like physiologic things, not just circumstances that are contributing to these mood changes. So if someone says that that's like their overriding symptom, not really as many hot flushes, but it's really like irritability and mood changes. Because I meet a lot of people who'd say like that's the main symptom that they're struggling with. This class of medications makes a lot of sense for them.
Yeah, there are times when I have a murderous rage for no reason. It is interesting because I have some friends who are going through perimenopause, and they also have a young teen girl who are just entering, right, with all the hormone
Yeah,
fluctuations. And you and I both have boys, so we don't notice that. But, I think about growing up in my teens with my mom, right? Like we were both just we fought a lot, and it's like the perfect storm with the two different
yeah,
hormone cycles.
yeah. And we have like so much thought in our society about the hormone changes of like the teen years, and I think we're just starting to think about all these hormone journeys of the menopause years.
Yeah.
It's also worth saying that outside of hormone replacement, there's like a newer class of medications. I just want to make sure I wrote it down so I could make sure I conveyed it properly. Neurokinin B antagonists. So the most common one is Veoza or fezolinetant. And this is a medication that really works at the level of the kind of temperature sensor in the brain. So it treats hot flushes that way. Yeah. So it's not hormonal. And as a Kaiser physician, it is not covered through our formulary, so it's very expensive. But I have had some patients who can't have hormones. They have breast cancer or strong family history, and nothing is, treating these hot flushes, that they're just debilitating, preventing people from getting through their day and doing their job. And they need something more. So this is another option. And it's a really exciting kind of class of medications that's just working in a different way.
Wow. It's amazing what medicine
Yeah.
finds.
Yeah.
Um,
Yeah.
and can you talk about the pellet? Because I know I have some friends who have gone on that and they love it or they hate it. Is that hormone replacement treatment? Like, what exactly is it, and do you recommend it?
Yeah. Yeah. So pellets are hormone replacement. They can have estrogen. Sometimes they have testosterone. They are not FDA approved. And I don't do them as part of my practice, but I offer so many types of other hormone replacement strategies. And so sometimes I feel like people often are kind of pellets are never going to be covered by insurance at this moment because they're not FDA approved. So a lot of people are paying a lot of money for these things. And I get it. They're not feeling heard. And I just want to make sure that people know that myself and other physicians offer lots of other treatments. I don't offer pellets, but I can offer many bioidentical FDA approved hormone replacement therapies. I also do some um, compounded medications. I try to start with the FDA approved medications, which are not compounded. Compounded medications are made in kind of like in batches, for you.
Okay.
So they're not regulated by the FDA, but there are lots of these like bioidenticals that are FDA approved. I don't necessarily think that things are bioidentical or perfectly safe, and things that are synthetic are dangerous. I think both kind of categories of medication have their place. But traditionally, our hormone replacement therapy were synthetic estrogens and synthetic progestins. But now we have a lot of estradiol, which is bioidentical, and we have a lot of progesterones that are micronized, and very similar to what you would make naturally. So I try to offer people those. When I offer hormone replacement therapy, estrogen is the biggest part of it. That's really what's going to treat hot flushes. You need the progesterone to balance the estrogen, because without it, if you have a uterus, that puts you at a high risk for uterine cancer, to have estrogen without the balance of progesterone. If you're that person who got their Mirena IUD for irregular bleeding, that's your progesterone. It's a synthetic, it's a progestin, but you've got that protection for your uterus, and then you can add an estrogen. The best way to get estrogen is transdermally through a patch. Because it helps you use the lowest dose that you're getting in a really nice, even, steady state. When you take estrogen by mouth, it's kind of ups and downs. Like, you swallow it and it gets ingested and metabolized, and you have like peaks and troughs of these levels. But when you do it through the skin, you get a more constant, steady state. It's also not having to go through the liver. So it's avoiding what we call like first pass metabolism. And the liver is where clotting factors are made. And so we really do think that when you get estrogen through a patch, you have a lesser risk for increasing your risk for having a blood clot in your legs or lungs, because estrogen does increase the risk for that. So if you're a person who's had a blood clot or a stroke, we really need to talk about other strategies. But yeah, so the patch is a really nice way to go.
How do you know if someone's getting enough estrogen then? Is that then, do you test after that, or is it mostly if symptoms sort of fade or if symptoms
Right, right.
alleviated, or
Yeah, it's really about your symptoms. Yeah, yeah. Unfortunately, looking at your levels in a blood test doesn't correlate with your symptoms. And so if a person is in the early stages of perimenopause or early menopause, I use a higher dose than someone who's been in menopause for a long time. Of the patch, you'll definitely meet people who encourage a lot of testing, saliva testing, urine testing. There isn't strong data for that, and often that is how people make their living, is through these lab tests. And so I've been lucky that, I tell my patients, like, if you are curious, I am happy to order that for you, but I don't make more money by ordering more tests. But I want you to be satisfied. And if that helps you kind of understand your process, I will order that. But I don't have a nomogram to say that you're going to feel great at this serum level of estrogen. The thing that I do test, though, is testosterone. And that's kind of a tricky
yeah.
conversation.
I have some
Yeah,
people
yeah.
who are say it's been great, and then other people say it made them ragey. Um, like, uh, how does that fit into it? Is that considered hormone treatment as well? It's just kind of maybe an add-on.
Yeah, yeah. It is. And so a lot of people will notice lower libido around the time of menopause. And it's a really complicated um, issue, because there's so many components to that. And so one of the little aside plugs that I'd say is, if this is something, that you're suffering with, like, please make sure that you have time to talk about this, because I can't do this conversation justice, like at the end of your well woman exam as an add-on, like, and sometimes people feel blown off by their providers. But this is a big conversation, because there's lots of reasons to have low libido, and it very well can be mostly hormonal, and hormones are certainly going to be a big part of it. But a lot of it could be your relationship with your partner, your communication, the time that you set aside for intimacy, the stress that you have in your life, with your work, with your kids, with your general like mental health status. Because if all of those things are a problem, you're not going to have as much energy to, feel aroused and intimate and to have orgasm. And so you do want to make time for that and optimize all of those things. The other thing to think about is that if people have painful intercourse, that's a big part of it too. And treating vaginal dryness or painful intercourse is a lot easier than adding testosterone replacement. I'll just get into that really quick before we talk about testosterone and libido. But some people tend to not struggle as much with vaginal dryness. People who are more regularly sexually active maintain like those healthy, elastic vaginal tissues and have less pain because each active intercourse shunts blood to the vagina and keeps those tissues really healthy. Some people, so it's kind of one of those, like, if you haven't been active in a long time and you're in menopause, you're going to feel very differently than someone who's been more regularly sexually active. Some people can manage their symptoms really well with over-the-counter treatments. And so these things are very worth talking about. That lubricants with intercourse that are silicone-based are really good. They're a lot better than water-based lubricants. Unfortunately, the things that are easiest to get at like a Target or a Walgreens are water-based, like KY gel or even Astroglide. Not all of it is a silicone-based. The brand that I recommend the most is Good Clean Love or Slippery Stuff. A lot of pharmacies have this brand now, and Amazon has it. You want a lubricant, so that's, what you'd use with intercourse is a lubricant, and what you'd use daily would be a vaginal moisturizer that has a low pH because the vagina should be acidic.
So some people use a vaginal moisturizer every day? Oh,
yeah,
okay.
Yeah.
That's new to me.
Yeah.
I'm learning.
Yeah.
And is that like, is that something people should do at a certain age or only if they're symptomatic?
If you have symptoms, if you have like vaginal irritation and you've come in to see your provider and it's not a yeast infection or BV, and, people can get gonorrhea and chlamydia and other infections at all stages of life, and you've been ruled out for those things, you do want your provider to look at the tissues of the vagina and make sure it's not something else. People could have vulvar eczema that only develops later in life, or there's other skin conditions that could actually be precancerous syndromes or cancer. Those are really rare, but you do want an exam. And if all those things have been ruled out, a lot of people can get benefit from just an over-the-counter vaginal moisturizer. So Replens makes a nice one. Good Clean Love makes a nice one. But the things you'd want to look for is a low pH, less than 5. So it's acidic, like the ideal pH of the vagina, because a higher pH can cause like a different balance of bacteria and can make you more prone to yeast or bacterial vaginosis. Bacterial vaginosis or BV is something, it's our normal bacteria, but in the wrong composition. And it can be itchy, can have an odor, can have a discharge. It's very annoying, even though it's not dangerous. It's just very frustrating. And so sometimes people do use oils, olive oil or avocado oil, coconut oil. That's not the right pH. So maybe some people are not as sensitive and that works for them. And if they're doing that, that is great. But for a lot of people, it could make a more basic pH and could make you more vulnerable to infections. So just to be aware of that. So finding a lubricant or moisturizer that's acidic, a low pH, and that has a low osmolality.
That's quite the word. Yeah. Okay.
Yeah. So it's not like pulling moisture.
Okay.
Something that's a high osmolality is like pulling moisture away from the cells. If you've used these things, you might notice like at first they work really well. And then you feel like even worse than when you started, like the tissues feel even more dry. And it's kind of like the cycle of having to use more and more and more, because a lot of the more, traditional ones that like you see first, like at Target, they will make you need to use more and more of it because they have a high osmolality. So you want a low pH and a low osmolality. So if someone is, if that's part of their low libido is that they have a lot of pain and they associate intercourse with pain, I want to make sure that that's optimized, because if those over-the-counter things aren't working, then we go to vaginal estrogens. And this is a super common treatment. vaginal estrogen works really well to make the tissues, more pliable, to improve pain with intercourse. Vaginal estrogen can be in the form of a cream. I mostly prescribe estrace, which is a bioidentical form of estradiol. There's also tablets. The most common brand is called Uvafem that you place in the vagina. And by tablet, like they're the size of your pinky, they're kind of big, but you'd put them in at bedtime. And then there's a ring called the S-ring that also has bioidentical estradiol that sits in the vagina for 3 months at a time. And having that improved elasticity to the tissues, not having pain, having improved blood flow to the vagina, to the clitoris, to all of those structures, for a lot of people, that can be their solution. And they don't need to do like a systemic treatment that has more risks with it. So it's worth just making sure that we've optimized that. Another thing that's like newer to me is using vaginal DHEA to treat vaginal dryness. That's like being recommended more and more by the Menopause Society. I've just started that in my practice, but there's good data for that too. So that can be options. The Menopause Society and the American College of OB-GYN recommend that we start with our FDA approved treatments for low libido first. So first seeing how people do with adding estrogen, because estrogen does interconvert to testosterone. So for a lot of people, they feel much better with just adding estrogen. For some people, that's not going to be enough. We do know that testosterone in and of itself very much does help libido.
Is that the only thing it helps? Or does it also help the weight gain too, right?
I don't know. I don't think that that's like, it can help you with muscle. And so that can help with weight gain. I think there's a lot of kind of touted benefits to that, because the tricky thing is there is no FDA approved form of testosterone. So the people that are offering these therapies may need to really sell it, because these are like out of pocket sort of things. And so it can probably, like all the hormones, be associated with everything. We don't have long-term safety data on testosterone, and yet there is no FDA approved version of it in the United States. So it's kind of tricky. So, yeah, it's pretty rare to see people who really, I know people feel that they have low testosterone, and that's a real way to feel, but who truly, are out of the normal range. Not many people are, but again, like your levels don't correlate to symptoms. But since I don't have an FDA approved version of testosterone to offer people, I do, for people who really do need it, use compounded testosterone in the form of a troche, like a little waxy tablet that you absorb under your tongue.
Oh, interesting.
And since I don't have good safety data for that, I try to just keep people in the physiologic range, like the normal range of a premenopausal woman. And so I do follow those levels like 6 weeks after starting testosterone therapy and at 6-month intervals. For people that are premenopausal, there is an FDA approved treatment for low libido called Addyi or flibanserin. And it is also like in the family of SSRIs, but it has been shown to increase libido. You can't use this medication if you've had alcohol. You'd have to wait a few hours before using it or not use it that day. And so we just need to be very careful about your liver and that. But that's out there. It's a newer medication and it's pretty expensive. So it doesn't suit everybody, but that does exist. But the person should be premenopausal.
And how do you, I know that I've kept you a long time. I'm just, for people who aren't, well, even for your patients, like what kind of appointments should they make? Because a lot of us struggle with making appointments, right? Like you have to wait 3 months to see your provider. I mean, that's not at all practices, but I would think it's, within the range of normal, right? Like what kind of appointments are you making? Because you're saying that some of these conversations shouldn't just be at your wellness or your annual visit, right? So what are you calling to ask for? And how do you know if your current provider, like, how do you know if they're as informed as you are?
Yeah. And so maybe at your well exam to say, I really want to talk about this. I know there's a lot of options. I'd like to schedule another time to talk with you. And then you'll get to know if your provider feels comfortable having that conversation, or maybe they'd want to refer you to someone else who does, or just schedule a menopause consult. I usually get 40 minutes for those visits, and a well exam is just 20 minutes for me. And in that time, I'm, trying to do your breast exam, assess your breast cancer risk, because none of us are low risk for breast cancer. All of us are at least moderate risk. Doing your pap smear, talking about general wellness, colon cancer screening, bone health, all of those things. And so it's hard to get a really good conversation. And these conversations are so nuanced. There's so many options, just to make sure that you have the time, because it's true that not all providers are comfortable talking about menopause. It is not part of a typical residency training. It's something that someone would want to learn about usually after their residency. So I would say not everyone is comfortable, but I would say, at least in my practice, most of us are, and we want to have these conversations, but to feel like you got a good answer, you just want to set aside that time. And so to schedule like a menopause consult or at your well exam to schedule that so you get the best plan for you.
I know we've spent a lot of time on menopause, and I thought we'd have more time for other things, but are there other women's health issues that you see more and more of as that we should be thinking about as we age?
Yeah. So bladder health is something that I talk to people a lot about. And a lot of people aren't aware that there is a huge spectrum of options to help with leakage of urine, having the urge to go, not being able to hold, your bladder. Vaginal estrogen can help a lot of people. There's a lot of pelvic floor therapy out there that's really targeted to bladder training. Even just being conscious of your diet, foods that are healthy foods can be bladder irritants, especially for people who have urge incontinence, or like when you have that urge to go and you can't quite hold it. Just looking at your diet and seeing like if there's caffeine or acidic foods, that can help. Like, for example, I don't drink coffee before I go to yoga because I know I may struggle. I still drink coffee, but I like modify my day. And I know that if I'm about to like be walking around and working out, like I don't want to drink coffee. So that's urge incontinence. There's also stress incontinence, like when you cough or laugh or run, and that's more about muscle changes of the pelvic floor. And everyone has this to some extent, but different people have different core strength and, muscle changes from their delivery. So it's going to affect everyone differently. But for stress incontinence, we can offer a lot of things. So vaginal estrogen can be part of it. Pelvic floor can be part of it. But for this particular problem, something like a pessary, which is a silicone device that sits in the vagina, and pushes up on the bladder, is something that I fit people with. And that can be something that you use just when you exercise. Some people just use a tampon. There are tampons that are specifically for bladder leakage that have a different shape. The Impressa brand, Poise tampons, I've seen them at Target, and they kind of have a more square shape, and they push up on the urethra. And so that can be a solution for some people.
So this is
other
just
people
aging. Like it could happen like in a year or two, these things, you just kind of notice it. Or, I mean, I definitely have friends who, after birth, if they sneeze, right, it's a problem, right?
Yeah.
Since I didn't have that, I kind of thought I was good to go, right? But that's not the case.
And you are a really healthy weight, and I bet you're really diligent with your exercise, and that's a big deal. Because if we are higher weight, there's just more pressure on the pelvic floor. And if we don't have good core strength, that also affects us negatively. So being the healthiest version of yourself also is a big deal for your bladder. But some people, just as they go through menopause, having the tissue changes of low estrogen could make these problems more noticeable.
Interesting.
And so they may want to consider these options. And then there's a lot of surgical treatments too that are very minimally invasive. So like collagen bulking injections at the urethra or a sling procedure. I'm lucky since I, would only be doing a handful of these every year as a general OB-GYN. I get to refer to a urogynecologist. So they're OB-GYNs who've done a fellowship in pelvic floor. And my partners who do many, many slings every week. They're really good at it. And that can be a game changer. My mom is always walking around and doing her errands on foot. And I don't think she'd mind me saying that, like, getting her sling was life changing. You know, she could walk for days. She's done, 2 Caminos, in
Oh,
Spain, where
yeah.
you walk across France and Spain, and she'll do a third. And, those things are really hard if you're, also dealing with urine leakage. So there's lots of solutions out there. So please know that it's an everyone thing.
No, that's good
Most
to
people,
know.
some
Yeah.
people
You don't want to talk
don't
about
struggle
that,
very
right?
much.
Yeah.
Yeah, but it's, there's lots and lots of treatment options we can offer people, even people who are like, I know I don't want surgery. I just had surgery. I don't want it. But there's lots of things that we can do.
Is there a certain age that people start having that surgery, or is it kind of wide ranging?
Yeah, so if you want a sling procedure, you definitely want to do it after you're done having your kids. Um, I'm sort of waiting, for the perfect time for me, but I kind of think, around 50 is a good
Yeah.
age because sling doesn't last forever. Like, all the gravitational forces that got you there in the first place can happen again. So you don't want to do it too soon, but it's also life changing. People, really, really, like it. So, I'll probably be there in a few
Oh,
years. I'm,
no,
I'm
that's
waiting to
really,
be closer to.
I had no idea. So I always close the podcast with you as a obviously busy and well educated, and like, thank you so much for sharing all of your knowledge. How do you maintain your own personal balance and peace? I mean, we talked a lot about stress today and how that affects things. How do you do that for yourself?
I wish I knew. I don't. I'm working on it. I'm working on it. I don't think I'm there at all. Yeah, it's a busy time. Kids are growing up, and I'm near my parents, and they help me, but I help them, and it's just a really busy time of life. I definitely don't have all the answers, so I'll keep listening to your
Well,
podcast
I
for
mean,
more tips.
it's why I ask it, right? It's like I want tips. I want what other people do. And then the other question I ask is, I have clients who are retiring or who have retired, and I read a lot of studies, and it talks about how hobbies and interests outside of your work can really make all the difference in your retirement. I mean, you can see that with your mom. She's so busy. She has so many hobbies, and she's so alive. Do you
Yeah.
have hobbies or and again, this is so that I can steal them. So, do you have anything
Um,
that's kind of that you love to do when you're not working?
Yeah, I'm trying to get to the gym. I'm trying to do
Yeah.
yoga. I'm trying to do my weight bearing exercise. I love to read. I'm in a book club. I love to travel. But my mom is a huge inspiration.
Yes.
She was really busy when she was working, and I wouldn't say she was like perfect at working out and, being perfectly healthy, but as she's retired, she's just always
Yeah.
moving, and she's just always walking. She's super engaged with everyone, with our neighbors, with her friends, with my kids. And I think it's kept her like really sharp. And
Socializing is
so,
huge. That's what all the studies say. I
yeah,
mean, and I'm talking about from the financial aspect. If they're talking about it in my curriculums, it's just it means that it's working, right? That it's such an important piece.
yeah. And like, she not only knows the names of all their friends, she knows their
Yeah,
allergies. She knows how to drive to their
yeah,
house. She knows like what Lucas
yeah. Your
likes, what
mom's
Lucas
amazing.
doesn't like,
Yeah.
all those things. Because it's also, one thing I didn't say is that a lot of people notice cognitive changes around perimenopause. And that's definitely a thing. Specifically, we know that like word recall,
Yes.
is harder. Yeah. But the things that aren't impacted so much are just ability to learn and like general cognition, but word finding ability is really hard. And that does get better. We think, when you're solidly in menopause, and I feel like my mom is really like living
Oh
her
my
best
gosh.
life in
She's like
menopause.
my
She's working hard at it.
retirement hero.
She's
Yes.
been about like walking, moving, making new friends, learning new things, trying new things. really focused on healthy eating. So hopefully I'll be there one day, but I'm totally not. But yeah,
It's
hoping
life goals for
to
all
learn
of
more.
us. She should
Yeah.
actually, maybe we'll have her on the podcast as the how to. And what's the
Yeah.
best way to find you? I mean, obviously, you have to be a patient at Kaiser Permanente to be able
Yeah.
to see you as their doctor, but
Yeah. So I'm at the Kaiser Aurora Centerpoint office.
well, thank you so, so much. I feel like I've learned a
Thanks for
lot.
having me.
Um, and we'll see you soon.